That's great. Thank you, Jonathan, and thanks everyone for turning up tonight. And this is going to be very difficult for me because the talks are being videoed and I've been told not to pace, and I'm a natural pacer, so if you see me clinging desperately, that's why. So, as Martin said, I'm going to talk a bit about what happens after the pain management program. So Martin's described what we do in the 12-week pain management program course for the patients, and I'm going to talk about the follow-up afterwards, the outcomes that we measure, how we deal with, or how we'd advise and help you to deal with ongoing pain management problems in these patients after discharge. And also, just briefly, I'll talk about future plans that we're thinking about to maybe improve the service that we offer after the pain management program. So we run a 12-week program, and then we see the patients twice after they've completed the program, after the discharge. So the first time we see them again is a 3-month review, which is really like an outpatient clinic appointment. So we just catch up with them, how they've been doing with all the strategies we've taught them, how they're getting on with going after these goals that Martin was talking about, if they're having any problems with medication or anything like that. So it's just a quick sort of outpatient contact. And then after 6 months, we see them again for a top-up session, which is a sort of condensed version, a Reader's Digest version of the pain management program. So we review the main content of the program and remind them again about pacing, goal setting, and so on. We also reinforce the possibilities for contact with outside agencies, and this is something I'll talk about later on in the talk, various agencies that can help provide support after the pain management program. And it's at this point that we start to look at outcomes. So from the moment we set up the program, we've always been quite rigorous and sort of keen on collecting outcome data, and we keep this all stored centrally, and we analyse this at regular intervals. What we measure is a series of questionnaires, 4 groups of questionnaires given at assessment, while they're being assessed for the pain management program, immediately after the 12-week program, and then at the 3-month review visit and the 6-month follow-up. So what we measure, it's really the things Martin was talking about in his talk. So we measure pain levels almost as a by the by, but what we're really looking at is, have we made any changes in acceptance, fear avoidance, fear beliefs, disability, and anxiety and depression. The data that I'm going to talk about, we don't have a control group for this, so we don't have a waiting list control to compare these figures with, but we felt it probably wasn't necessary for this patient group because, I mean, as we all know, spontaneous remission for chronic pain patients, by the time that they sort of reach the pain management program stage, spontaneous remission is quite unlikely, or very unlikely. So this flow diagram, this is from a paper that we're in the process of submitting for publication. It's just really looking at initial data from the first patients that we saw in 2008 up to, I think, the end of 2011, just to include the follow-up period as well. So just to give you an idea of the numbers that I'll be talking about for the following few slides. So basically at the bottom you can see we've analysed 309 patients attended and completed the program, and we had some dropouts during the program. Unfortunately, as with any sort of study, when you're wanting patients to fill in questionnaires, often they don't fill them in completely, they miss out bits, so we had to discard 100 of these questionnaires of the 309 who attended because of insufficient data. But the shaded boxes mean that we've compared these groups with the groups for whom we do have data. We've looked at things like demographics, indices of deprivation, as well as the raw scores and the questionnaires themselves to see if there's any difference between the groups. And in all cases, there are no significant differences between the groups. So we're fairly pleased that the results that we've got apply to all the patients who are being referred into the pain management program. The first thing we look at is just pain rating itself, the familiar numerical rating scale, the 11-point item from 0 to 10. And we, as is usual for these things, we ask them about pain currently, their recall of pain in the past week, their recall of the worst pain, and then pain at its best. We're not, the pain management program is obviously not about pain control, so we don't expect any of these to change. And as you can see, we don't get any change in current pain. When we're looking at recall of pain in the past week, well, there is a significant change. I mean, you can see it's a very small effect size we've got here, but from assessment to post in 3 and 6 months, there's a slight but significant change. And also, when patients are asked to recall the worst pain in the past week, again, a small but significant change. And it's not clear why this should be. I mean, maybe because this is recall, and recall is going to be influenced by, you know, mood and distress, then maybe if they're less distressed now, they're going to recall this as better, or possibly because we've been discouraging uncontrolled activity, and, you know, hopefully we're preventing flare-ups. Maybe that's having an ongoing effect. And best pain, no difference. So Martin's already mentioned this chronic pain acceptance questionnaire. So this is measuring this concept of acceptance, or you can almost think of it as psychological flexibility. So how willing are patients to do things despite having the pain? And if you look at some of the questions there, just to give an idea of what it's measuring. So I'm getting on with the business of living no matter what my level of pain is. My life's going well even though I have chronic pain. So you can see the idea of what it's measuring, and Martin's already mentioned how this ties in with prediction for return to work, etc., etc. A low acceptance score is a bad thing, and a high acceptance score is a good thing. That's the direction it goes, and you can see that we seem to do quite well in changing patients' CPAQ scores, acceptance levels. So at assessment, they score reasonably low, but by immediate post 12-week program, they've made a significant change, significantly improved with a large effect size, and that's sustained at 3 months and at 6 months. This is the TSK, and it's beloved of physiotherapists. It's one of these things that's, you want to say it in an American accent, but it's the Tampa Scale for Kinesiophobia, or fear of movement. And that's related to the models Martin was talking about earlier. And the font isn't very clear to read here, but if just reading off some of these questions to give you an idea of what we're measuring here. My body is telling me I have something dangerously wrong. Pain always means I've injured my body. So that's the type of sort of fear that we're measuring, and fear of movement. And you can see that at the start of the program, or before the start of the program at assessment, our patient group are a very fearful group. They score quite highly in this, and we make a significant change to that, which seems to be maintained, so even slightly improving at 3 month and 6 month intervals. Now the eagle-eyed amongst you will notice that I'm cheating a bit here, because the graph's a bit cut off, but it's, you know, just really to make it more clear. But so this isn't as large an effect size as it looks. This is a moderate effect size, but, you know, it's still a reasonable change. The Oswestry Pain Questionnaire, this is a general measure of disability in pain patients. I don't think Martin's a big fan of this. It probably doesn't tell us too much. Most of the measures can be affected by many other things apart from pain. We seem to have a good effect on that at the end of the program, but this doesn't seem to be sustained at 3 and 6 months. It's a bit disappointing. And then finally, moving on to the hospital anxiety and depression scales, or HADS, and again, I'm sure this is a measure that most people in the room will be familiar with. Just a screening measure for anxiety and depression in a general medical population. So it's not specifically designed to look at pain patients. And this questions as to how appropriate it is to use for pain patients. Some of the items are maybe not necessarily picking up depression or anxiety. There might just be a byproduct of pain. For example, item 8 that you can see in the top right there, I feel as if I'm slowed down nearly all the time. Well, you know, pain, disability will slow you down. But yep, there's 7 questions for anxiety, 7 questions for depression. For each item, you can score between 0 and 3. So you can score between 0 and 21 for anxiety and 0 to 21 for depression. And a score of 12 is generally taken as a sort of cut-off point for clinically significant anxiety and depression. So looking at our patient group, you can see that before the program, they're quite an anxious group, as you'd expect. They scored just below the sort of clinically significant cut-off point. And we make a significant difference with a sort of moderate effect size at the immediate post group point, and then this is sustained, and even with a slight improvement at 3 months and at 6 months. Likewise for depression, again, this is a patient group with quite high levels of depression to start off with, but we seem to make a reasonable difference to this. Again, a moderate effect size. Interestingly, this is not only sustained at the 3-month and the 6-month period, but it seems to improve slightly as well as we go along. So we were quite pleased by that. And maybe we'd like to imagine that this is a reflection of the fact that patients are starting to break out of the rut that they've fallen into. They are starting to engage more in valued activities and just starting to get out and about and have more in their lives than just the pain. And this idea that they're starting to do more, this is really reflected in some of the stories that the patients tell us after the program. So as well as getting them to fill out questionnaires, we also ask them to just put in free text comments, and they let us know how they found the program overall, any big changes they've made in their lives. And you can see from some of the comments here, we hear things like, I've enrolled in 2 college courses as a result of the group. At first it didn't seem that different to other groups, but by session 5 and 6, my outlook was changing. I was becoming more optimistic about living with pain. I mean, so obviously this is wildly selective reporting here. I'm not giving you all the comments when they said yous are all rubbish, but you know, it reflects what we hear a lot of the patients saying throughout the group. This is something that Martin more accurately has been collecting recently. We teach them a lot in the program. We go through, there's quite a lot of different talks that we go through, and we wanted to make sure that the things we were teaching them were things that people would find helpful. So Martin looked at, what do you wish that you'd known earlier on in your sort of pain career? So having been through, you know, probably orthopedic clinics, general surgical clinics, pain clinics, and then finally the pain management program, at the end of all of this, what do you wish somebody had told you sooner? And we were really interested to see how that came out. So thoughts and feelings came out on the top. Explain pain, medication for pain reliefs. So generally, what was coming out, you know, reasonably reflects the content of the program and how much weight we assign to the different elements of the program. And it was really interesting to see at the bottom the role of surgery and injections was way down there. So presumably these patients, they've been disillusioned by what's happened in the past with previous surgery, with previous injections. It'd be interesting to see, and it's something that we're hoping to do in the future, is to look at patients attending the pain clinic for the first time and seeing if there's any difference between what they're hoping and what they're expecting at that stage. So I'm presenting quite a positive picture of the changes that patients make on the pain management program, and we'd like to imagine that they go to the pain clinic, they have the best possible advice in terms of medication, they have injections where appropriate, and they go through to the pain management program and they're taught all these self-management strategies, which at the end of the 6-month period we can sort of wave cheerio and they'll be happily self-managing their pain for forever afterwards. But obviously in real life that doesn't happen, and we don't know what goes on in the community, and we don't know how often these patients are coming back to you in primary care. But what we see in secondary care is that a lot of these patients end up being re-referred back into the pain clinic. So this is something that we looked at last year. We looked at all the patients who'd been through the pain management program from 2008 to 2010, so that gave us a sort of 2 to 4 year follow-up period afterwards. And what we found, that of the PMP graduates, 16% of them ended up being referred back into the pain service. So some of them were just seen once and then discharged again, but the vast majority of them were seen quite a few more times. The most common reason for re-referral was flare-up of pain. and most of the referrals came from primary care. So, although when we set up the pain service, the pain management program as a pain service, we'd hoped that this would be an exit strategy, but probably it's naive. I mean, it's probably true to say that there'll always be a proportion of patients who will need some form of ongoing care, and this is what we're sort of struggling with at the moment, and we're not sure what to do about these patients. So for the rest of the talk, I'm just going to talk about ways in which, advice that we can give for how you might manage these or deal with these patients when they come back into primary care, and also talk about a couple of things that we're looking at to maybe get more of an idea of how to deal with this problem in the future. So what can you do in primary care to support changes following the pain management program? Well, before I say this, I mean, obviously my disclaimer here is I'm speaking from a position of ignorance. I don't know how these patients present back to you in primary care, but what we found in our little audit suggested that the majority are coming back with flare-ups. So if they are coming back with flare-ups, then reminding them of some of the things that they learnt in the pain management program, linking exacerbations to activity, encouraging regular activity, sort of preventing this boom and bust cycle that Martin was talking about earlier. These will all be helpful things, encouraging graded increase in activity. Promoting engagement with the world through valued activities. So on the program we use goal setting, we get them to think about values, we use goal setting. And a gentle reminder of this, you know, the patients all have their manuals. They should still have their manuals somewhere in the house. We give them lists of other agencies, what's out there, which I'll come to again in a minute. The other thing, again, as Martin said earlier, there's obviously a close link between anxiety, distress and pain. And I mean, certainly in my experience, seeing patients who've been through the pain management program coming back into the pain clinic, a lot of the time what they're coming back in with, it's not really a change in their pain, it is just an increase in their anxiety. And often it's something completely extraneous, social difficulties, you know, problems with family, problems with work. They failed their ESA assessment. So all these things feed into increased anxiety and then going off the rails again, becoming stuck in a rut again. So all these things are connected. And obviously that we're very limited in what we can do about these social problems, but just recognizing this and being able to support them in any way we can, I think this is a helpful thing. I suppose along with recognizing this comes with recognizing that they're not looking for more medication or more investigations, and often by the time they've been through the pain management program, the patients tell us this over and over again. The last thing they want is more, you know, more stuff, and it's easy to get in that situation when you think, well, I'm sitting here, they've come to me, I've got a prescription pad, I need to give them something, and you know, it's something that it happens to all of us, and sometimes just taking a step back and recognizing that might not be what people want. And again, the things like mindfulness meditation is something that we've found helpful. The patients seem to find very helpful in the program, and we give them a mindfulness CD, and there's a lot about mindfulness in the manual. So just, I suppose, just gently reminding people and redirecting them to these sort of resources can be a useful way of helping with anxiety management. So as I said, during the pain management program, we have a couple of talks just directing people to support agencies that they can use for support in the future. There's a huge list of them. I mean, probably most of them will be familiar to you, some of them maybe not. I suppose a good place to start is looking at directories or sort of repositories of information sources, and there's a few good websites there that sort of break down these things into categories. At both the new ACHs, the Victoria and the Stubb Hill Hospital, there's sort of live information desks that sort of staffed throughout the week. They run various events, and they're also able to sort of direct patients to appropriate agencies. This The physical activity, these are things that I'm sure you'll be using all the time, and we've certainly found them very helpful. Things like the Live Active scheme, most of the staff there seem to be very tuned into things like pacing and graded increases in activity. There are lots of support groups, as well as condition-specific groups like Fibromyalgia UK and Fibromyalgia Action. There's also sort of general chronic pain support groups. And we've worked closely in the past with the Pain Association Scotland and with Pain Concern as well. Pain Association Scotland run a group specifically for PMP graduates that runs at the Templeton building where the Pain Management Program runs itself, and they also run local groups throughout Glasgow. So at the pain clinic we always give leaflets for the Pain Association. I'm sure you've got all the details there. So as to the future, well, something that we're in the process of developing, just on a very small scale, is some sort of telephone helpline for patients. So once patients have completed the pain management program, where can they go if they have a flare-up? If they find they're struggling with some of the things that they've been coping with well in the program, if they've got questions about medication. So starting on a small scale, just with myself and the clinical nurse specialist at the Pain Management Program, we're going to just try and offer a very limited sort of support telephone helpline, which we've not started yet, but we'll see how that goes. And if that proves to be useful, or if the feedback is good from that, then it's maybe something we can extend out to the pain clinic itself. One of the things that we talk about in the pain management program, one of the talks with the patients, is looking at what will happen after you've been discharged from the pain management program. And what comes out again and again from patients is that they don't like the idea of being discharged with no follow-up at all. They feel that they're sort of floating adrift, and even if they're not necessarily seeing somebody on a regular basis, they like the idea of being under the care of someone. So maybe this would be a way of sort of fulfilling that need. We'd love to measure the effectiveness of the pain management program of these self-management strategies. We'd love to see if this makes any difference to your experience in primary care. So, what we'd like to hope is that we teach a lot of strategies specifically for pain, but do these strategies relate to better self-management for illness overall? In England, self-management projects, one of the outcome measures they often use is primary healthcare episodes, because the way the health system is running in England just now, these are costed, they're all stored and kept in a central database, and they're easily accessible. So that's a useful outcome measure. But unfortunately in Scotland we don't have that, and certainly in Glasgow we've looked into this to see if there's any way of getting hold of sort of episode data from primary care in a way that's easily searchable, but we've been told that there isn't. If anyone knows any differently, then we'd be delighted to hear that. But that's something that we'd like to look at in the future to see if what we teach in the pain management program makes any difference to this. And certainly if we're developing something like a telephone helpline, then that might be another way of looking at that in terms of outcome of the service. So in summary then, we think that a self-management program is useful for patients with chronic pain. I think we've shown that what we do in Glasgow is reasonably effective, and we're hoping we'll continue to develop the service in the future. And as I said, we'll be pleased to hear from anyone if any ideas of looking into sort of outcomes after the pain management program, or problems that you have specifically with these patients after they've been discharged.